Good afternoon. My name is Kimberly Williams. I'm the president and CEO of Vibrant Emotional Health, and I am delighted to be joined this afternoon by the Surgeon General of the United States, Dr. Jerome M, to have a conversation about mental health and suicide prevention. To get us started, Dr. Adams, why don't you tell us a little bit about yourself and your background?
Well, the most important thing to know about me, other than that I'm Surgeon General, is that I'm a dad. I've got a 16, a 14, and a 10-year-old at home, and they really inform a lot of what I do and why I do it. I really am very concerned about the mental health and well-being of our young people, especially in the midst of the pandemic, and digging into the resiliency factors, the risk factors for mental health issues for them. Many people know, but it's worth mentioning here that I'm an anesthesiologist, and I still practice about a day a month at Walter Reed Medical Center. And I also used to run the State Department of Health in Indiana for 3 years prior to becoming Surgeon General. And in that role, I really saw the interconnectivity between mental health and physical health.
And so on that point, Dr. Adams, increasingly there's recognition that mental health is core to our physical health. And so I'd like to hear more about, from your perspective, why mental health is so important to our overall physical well-being.
Well, that's a great place to start, and I'll really begin at the beginning, if you will. A long time ago, we cut the head off from the rest of the body, is what I often like to say. We said if it happens from here on down, then your primary care provider will see you now and your insurance card will cover it. We said if it happens from here up, whether it's mental health, oral health, which I have a report coming out on later this year, vision health, that you have to see a specialist or someone who's completely out of the system in order to get it attended to. And in most cases, it's not going to be covered, or it certainly won't be covered to the same degree that a physical ailment from your neck down would be covered. And I think that's really been unfortunate, because you're not going to be able to comply with your diabetes regimen, or be successful in your cancer treatment, or to really deal with any of the other issues that plague us physically if you aren't healthy mentally. And one of the things you've seen over the last several years, which is good, is an integration of the mental and the physical and the emotional and the spiritual in places that are doing it really well. But the challenge is the system isn't built to reimburse for that. The system isn't built to have the right people in place to do that. And I think that's one of the things we have to really consider. W. Edwards Demings said every system is perfectly designed to get exactly the results that it gets. Right now, we're not getting great results, and it's because we have poor system design that doesn't integrate mental and physical health as much as it could or should.
I'd like to turn to talk a bit about suicide prevention. We're just closing out Suicide Prevention Month, which for Vibrant, which administers the National Suicide Prevention Lifeline, it's such an important time to join with our suicide prevention colleagues across the country to share resources and build public awareness about suicide prevention. Recent studies show that suicidal ideation among Americans is increasing. Do you have thoughts on why that is, and what we can do to address the needs of people who are in emotional distress?
Well, I have lots of thoughts on that, both as a physician and a public health practitioner, as well as a dad. We know that there's just an array of risk factors, of situations occurring that really are putting unprecedented levels of stress on young people, and in a way that you can't turn it off. Once upon a time, you had a bully at school. Well, at least you could go home and get away from that bully. And now you go home and the bully is there with you still 24/7 on the phone. That's just one example. But while suicide is a complex behavior that can be influenced by many different factors, I think the important thing to understand is that we've got a lot of research that tells us it's often preventable. It provides or requires a comprehensive approach that combines various strategies for identifying and supporting individuals and groups at risk. So we have to first identify them and then support them, and also prevent others from becoming at risk in the first place. Suicide prevention theory and research have long identified the social context, which I alluded to earlier, as crucial to protecting individuals and populations from suicide. So we need to be aware of, and we quite frankly need even more research into what is different about the social context for people today and in this moment than there has been in the past. Theories of suicide suggest that social factors such as social isolation, which many people are feeling now, and the feeling of being a burden to others, which again, many people are feeling now, may increase suicide risk. But opportunities are also major factors. We know that meaningful employment that pays a living wage, or volunteering or mentoring, has been shown to reduce suicide risk by fostering supportive relationships, as well as giving people a sense of meaning and purpose, because in many cases, people try to take their lives when they feel like they've lost that meaning and purpose. So these theories suggest that at our core, human beings need to be connected to one another and believe that they're making a meaningful contribution to society. We know that schools, workplaces, places of worship, and many other organizations in the community are opportunities for individuals to develop these positive connections and to be of service in meaningful ways.
So Dr. Artis, I want to build on some of the things that you said, because we know that there are particular communities, right, that are at higher risk, such as LGBTQ, BIPOC, young people you mentioned. Why do you think these communities are at higher risk, and how can we better address the needs of these particular communities?
Well, according to the most recent national estimates, suicide claimed almost 50,000 lives in 2018. Research indicates that from 1999 to 2018, the suicide rate actually increased by 35%. That's the top of the umbrella. That's the big picture, the 30,000 foot numbers. But there are, as you mentioned, high-risk populations. American Indians, Alaska Natives, lesbian, gay, bisexual, and transgender or LGBT people, working-age men, older adults are all in higher risk groups. We know individuals in child welfare and justice settings are higher risk. The military service members and veterans are higher risk, and we've been working with Barbara Van Dalen and the Prevents Task Force to really take a serious look at the fact that 20 veterans each day die by suicide. We have to look at individuals with a history of suicidal behaviors, because that's the biggest risk factor of whether or not someone will die by suicide, is whether or not they've made a previous attempt. What's interesting is we also know that individuals who have lost someone to suicide are in a higher risk category. And then this makes sense, but individuals with mental illness, substance abuse problems, and medical conditions are all at higher risk for suicide. It's often a co-occurring illness, and we need to make sure we recognize these risk factors so that we know for whom we need to intervene and when and where we should intervene. For every one person who dies by suicide, it's important to understand that 280 people seriously think about it and then find a way through it. So while there are at-risk groups, there's also a lot of data and a lot of evidence out there to suggest that we can intervene and that there are factors which help people get through those difficult times. But every individual and organization in the community has to recognize they have a role to play in promoting health and well-being, reducing risk behaviors, and increasing those protective factors for suicide that I mentioned earlier. For this to happen, we all must understand how we can help prevent suicide by supporting the implementation of effective suicide strategies. And that's really what Suicide Prevention Month and the conversation we're having today are all about. Things that we can all think about doing are helping everyone build life skills, coping, problem solving, resilience. And that's one of the things I worry about in our young people as they've gotten more and more attached to their phones, that they don't know how to problem solve. I heard recently that young people are less likely to get their driver's license when they turn 16. They are less likely to go out on a date with someone or have meaningful interaction. Again, when we look at the social context, fewer and fewer people are having these opportunities to go out and build these life skills and to learn how to deal with conflict. We need to help people promote social connectedness and support. Again, becoming more and more challenging as people are connecting not face-to-face, but over digital platforms. Identifying and supporting people at risk, which we talked about. Supporting lethal means safety. And there is a lot of debate, and there will be for the foreseeable future, about gun rights. But that doesn't mean we can't have a serious conversation about gun safety and about other lethal means when you talk about opioids and medications that are left around. We know that if you combine the means to try to take your life with the intent, that's the deadly combo. Many people think about it, but they don't have the means to immediately act on it. And that can be the difference between whether or not they're here tomorrow or not. We need to support access to effective care for everyone. And again, that's looking at the systems level to make sure there are intervention points in place and that people can actually get it in a manner that is reimbursed, or where they don't have to worry about then going bankrupt because they acknowledge that they have a mental health issue, or that they're going to be stigmatized. And we need to respond effectively to the aftermath of a suicide attempt, because again, we know that then puts you at higher risk for ultimately dying by suicide, but also responding effectively to the aftermath of a suicide death, a successful suicide attempt, because we know everyone around that person is going to be at higher risk.
Dr. Adams, you touched on a number of challenges that people face, which increase their distress or result in, suicidal ideation. And that's exacerbated now that we are in the midst of a pandemic. So I wanted to get a sense from you what your concerns are for people's mental health right now as the pandemic continues.
Well, I'll take a deeper dive after I frame it for you. But to put it very simply, almost all of the things that we tell people to do to protect yourself from COVID are the exact opposite of what we tell you to do to protect yourself from mental illness, mental health issues, depression, anxiety, and suicide. And we have to figure out how we meet in the middle, how we protect people from a contagious virus, while also providing them that connectivity that we know is incredibly important for our mental health and our long-term physical health. But long before COVID-19, I made it my mission to emphasize the importance and the interconnectivity of mental and physical health. And this pandemic has made it clear that each merits attention and action, and we can't afford to focus on one at the expense of the other. And unfortunately, we are only just beginning to learn about the true impact of this pandemic on the mental well-being of Americans. As of June, almost 90,000 Americans have developed symptoms of anxiety or depression related to COVID-19 induced stressors. With that in mind, now's the time for us to invest in prevention and early identification to get people the help that they need and deserve. We need to address fragmented systems and apply what we already know works to save lives. Also important to note, the pandemic has altered healthcare delivery and access to mental health services. So traditional means that people would present themselves have become more difficult to implement. When you look at coming into a doctor's office, and many offices are closed. Again, when I talk about separating the head from the rest of the body, mental health services for the last 8 months have been seen as elective. And we know that it's not an elective service or intervention when someone is thinking about taking their life by suicide. And because of that, I'm deeply concerned about the consequences on the well-being of our citizens. And I'm also concerned about the equitable access to services and resiliency among our communities, because we know that there's a problem overall for everyone, but these problems also are not equally shared by different members of the community. We know that stress can worsen substance misuse. And during this pandemic, we're hearing about just precipitous increases in alcohol misuse and in marijuana usage. And we know that when people are under the influence of a substance, that also increases the likelihood that they will attempt to take their lives by suicide. These pose added risks to mental health, but we know that our emotional well-being and resiliency can act as protective barriers against these risk factors. So by focusing daily on caring for our own emotional well-being, and I encourage you all to think about that today, what can you do to support your own mental health and well-being, but by also supporting the well-being of those that we love. I know we can successfully mitigate the mental health effects of COVID-19. That's literally why we're taking the time to have this conversation today, not just to say that everything's bad, but to say that there are interventions that we all can be a part of. And that's why I remain steadfast in encouraging Americans to use healthy mechanisms to cope and to band together to practice the evidence-based and the tried and true habits that we know will keep us safe and healthy in mind, body, and spirit. Make sure you're doing the simple things like getting enough sleep, trying to eat a healthy diet, because we know that what you eat can either lift up your spirit or bring you down. And again, trying to avoid misuse of various substances from nicotine to alcohol to tobacco and marijuana and beyond.
I think that's a really important, message for the public to hear, actions that they can all take to support their own mental health and well-being. So your office is soon going to be releasing a report on suicide prevention. And so wanted to spend some time talking about that. Why did you decide to focus a report specifically on suicide prevention?
Well, over the last 2 decades, we've worked to build a national infrastructure to expand resources commensurate with the breadth of the issue of suicide. And as we discussed in the previous parts of our conversation, unfortunately, that breadth is only increasing, it's only widening. But the good news is we now have infrastructure at the federal, state, and local levels, along with better science, better evidence, better service delivery to implement evidence-based practices that we know can make an impact. Again, the Prevents Task Force was put together by the President of the United States specifically to look at those who have worn the uniform who take their lives by suicide. But we know that what we'll learn from that standpoint will be applicable to many other settings and groups. Last year, the federal appropriation for suicide prevention was the most robust to date. Happy to see that. So we're now at a tipping point where we'll begin to see the results of our investment in infrastructure. And the call to action I'm going to be putting out in December will help to bring new attention and strength to these efforts.
That's terrific. Could you give us a sense of what's going to be included in the report, a bit of a sneak peek?
Absolutely. We don't want to keep this under wraps. We want to get it out as soon as possible. And we want to make sure people are putting the actions in the call to action into play into their lives. So I want people to understand a Surgeon General's call to action is an evidence-based summary document to stimulate action on urgent public health problems. We basically bring together experts, we look at all of the information out there and we say, what's the low-hanging fruit? And who are the target audiences that we need to help stimulate into taking action in their day-to-day lives? The national strategy is relevant and strong, and now's the time to accentuate the things that are most worthy of your attention and which have the greatest potential to impact to suicide. It's a time to highlight those areas where there's evidence for effectiveness, but also where we need to go to scale. There's a sense of urgency when talking about suicide and suicide prevention, again, because we realize that suicide rates are on the rise and actually will likely be increasing in the context of the isolation brought by COVID and the unemployment brought by COVID. One of the studies out there suggests that for every 1% increase in unemployment, you see a 1.3% increase in people who take their lives by suicide. There are evidence-based practices that we know play a vital role. And again, these are detailed in the call to action. It's going to have several areas of emphasis specifically centered around prevention, risk, and standard of care. The goal is not only to outline best practices for professionals, but to also address suicide head on as a serious health concern for all of us. And to name just a few of the emphases that will be seen throughout the document, we're going to be emphasizing the continuing need to improve the quality, timeliness, and use of data to guide suicide prevention. We want this to be a data-driven approach, and that starts at the local level, making sure reporting is occurring so that we can see trends in certain areas. Because what's interesting, fascinating to me when you actually study the research, is how you can have regional hotspots for suicide clusters, if you will. We want to make sure we can recognize them right away. We want to make sure we can tie them to other data. Is it occurring in an area of high substance misuse? Is it occurring in an area where we know we have a higher population of LGBTQ individuals? Is it occurring in an area where we've seen a lot of unemployment? We'll also be emphasizing the long-term foundational approaches that will be needed to broaden perceptions about suicide prevention and empower every member of society to play a role. And it will describe the components of effective care for suicide risk individuals, because most doctors don't, and nurses and pharmacists and health professionals don't know what to do, even if they do encounter someone who is at risk for suicide. So the first step is helping them understand who may be at risk, but then it's helping them understand, look, there are evidence-based practices out there. There are steps you can take. There are phone numbers and hotlines that you can call that have been shown to decrease the risk that that individual will actually try to take their lives by suicide, or that they'll be successful in their attempt.
Well, it all sounds really terrific, and we're going to be looking forward to the report being released. I wanted to get your perspective on stigma. As you know, there has been a lot of stigma associated with mental health and suicide. It's decreased substantially over the years. More people are comfortable talking about it, but it still continues to remain a barrier to help-seeking behavior. And so, why do you think people are still afraid to talk about mental health and suicidality?
Well, I'm so glad you mentioned stigma. I often tell people as Surgeon General, one of the frequent questions I get asked is, what keeps you up at night? What do you think is the biggest killer out there? And people expect me to say cigarettes because, hey, I'm the guy on the side of the cigarette box. People expect me to say obesity. People expect me to name all these other things, opioids. Well, I think stigma is actually our biggest killer out there, because whether you're obese and you're stigmatized because of that, or whether you have a substance use disorder and you're stigmatized because of that, or whether you're thinking about taking your life by suicide, but you're worried about what people are going to say about you. Stigma keeps people from acknowledging they have a problem and from seeking help even when they know they have a problem. I want people to understand suicide is not only a mental health issue, but it's a public health crisis in our country. 54% of suicides in this country are not in response to a mental health diagnosis. So important for people to understand from a stigma point of view that mental health and suicidality often co-occur, but they often don't. And that's a place where we need to help people better understand that people can be at risk even if they haven't been diagnosed with a mental health issue. Suicide arises from a combination of physical health, mental health, and environmental factors, again, like job loss, fiscal insecurity. Food insecurity can cause people to take their lives by suicide. And social isolation and lack of connectedness, like we're seeing now in the midst of COVID. So our response must address all of these issues, which individually carry their own stigmas, but also collectively add up to a greater stigma for someone who may not seek help when they need it. Like we've done with opioids, cancer, heart disease, and obesity, we need to continue to expand the national narrative to include the environmental factors in addition to the individual factors, because those individual factors are what people feel causes the stigma. A stigma is when we separate people into us and them. But when we recognize that there's a broader environment that we all exist in that can either put you at risk for suicide or can build resilience, then we lower that stigma. We need to give everyone an understanding again of how they can play a role. And we need an approach that inspires hope and resilience, because stigma also comes when you feel like there's nothing that can be done. So I want you all to help people understand that healing, hope, and help really are happening every single day. We hear about the stories of people who took their lives by suicide, but we don't hear enough about the people who thought about it and who may have even attempted it, but who were able to come through the other side. These stories of hope and recovery have the power to help others through a crisis and dispel stigma and myths about suicide. And I'm passionate about this topic. I don't want to go on too long, but we talk about peer recovery coaches for people with substance use disorder. And in many cases, these peer recovery coaches are individuals who have been through treatment and recovery themselves. And that really has been shown in an evidence-based way, in a powerful way, to help people who are struggling, who are at their low points, get through to the other side, because it's someone talking to them who can really empathize and who can say, I've been through this, and who can stand there as a model of success. We need to do more of that for suicide so that we can lower stigma.
That message of hope and recovery is so powerful. In closing, I wanted to ask you what message you would give to the average person, about what they can do if they're concerned about a loved one or a friend who is in distress.
Well, great question to end on. One of the things I want to talk about is a common myth that I hear, and that's that if you're asking someone if they're thinking about suicide, that will plant the seed or give them the idea to do so. There's a stigma against even intervening in a situation where you think someone may be at risk. And I want you to know that research shows this is not true. In fact, the research shows that asking them can help save their lives. It's myths like that push people away who are willing and able to help, and we must remove them from the narrative. We need to spend more time talking openly about our mental health with our family and our friends and within our communities. We need to normalize that conversation so that people understand it's okay not to be okay. We need to help our friends and family members know they're not alone and that everyone can find help. And this will prevent suicides and save lives. So pick up the phone, reach out to someone who you haven't heard from in a while, FaceTime them, send them an email or a text, or send them an old-fashioned letter. That small action can be the difference between whether or not someone thinks about or tries to take their life today. And as I stated earlier, we all must understand how we can help prevent suicide by supporting the implementation in our communities of effective suicide strategies, including helping everyone build life skills and resilience, promoting social connectedness and support, identifying and supporting people who are at risk, again, supporting lethal means safety. We need to, as a country, wrap our heads around the idea that it's okay to talk about lethal means safety, and that is different than talking about whether or not you have the right to possess these lethal means under normal circumstances. Because one of the most effective ways of preventing someone from dying by suicide is by removing their means to be able to take their life. And that's another myth I want you all to understand. There are a lot of people out there who feel, well, if I take one means away, they're just going to find another means. That's not true. That is not true, and we talk about that in my call to action. If you can stop someone from having immediate access to an incredibly lethal means of taking their life, you significantly increase the chances that they will have enough time to find the help that they need, or that someone will recognize that they need help. Which leads to the final point. We need to support access for effective care for everyone, and we need to respond effectively to the aftermath of a suicide attempt or a suicide death. I want you to know that there are free resources available 24/7 at the National Suicide Prevention Lifeline, 1-800-273-8255, as well as on the National Action Alliance for Suicide Prevention's website. So if you are having trouble or you know someone who's having trouble, one concrete thing you can do is send people to these evidence-based resources today.
Thank you, Dr. Adams, for this wonderful conversation. It was a pleasure to be with you and to get your insights on suicide prevention.
Well, thank you for the opportunity. I really appreciate it. It is a trying time, but I hope that it will be a time when we recognize that some of our systems were fundamentally flawed, and when we decided we were going to change these systems for the better. And one of the places where we can really change the system for the better is in the area of mental health and specifically suicide prevention. Every single one of us can play a role and has a role to play. And if we all do our little bit, it's like throwing that pebble into the water. It can cause a tidal wave on the other side of the earth if everyone throws their own little pebble in the water. If we do our part, then we can create a giant ripple that will normalize mental health and wellness and ultimately save lives from suicide, from substance use disorder, from an array of other ways in which mental health impacts our overall health and well-being. I'm convinced we can do it, and thank you for letting me share some of my perspective today.
Thank you.